Hey, my name's Poppy Redman and I'm a general surgery trainee. This video is about the Surgical Education Checklist, how to use it and why it may help improve teaching in the operating theatre. Surgical training has evolved significantly over time, but the operating theatre remains a really important venue in the acquisition of key skills such as technical skills and safe judgment that are required to make a good surgeon. But the operating theatre is a really challenging environment in which to teach. There are complex dynamics and different priorities between the anaesthetic, nursing and surgical teams, and there are lots of sensory stimuli including uncomfortable temperatures, physical discomfort, sounds, smells and distractions from phone calls, etc. In addition, there are many other factors that negatively impact education in the operating theatre. Patient safety is absolutely appropriately everyone's first priority, but learning in this environment can be inhibited by the high-stakes nature of the work. Reduced working hours have led to trainees spending less time in theatre than previous generations, and that inevitably has an impact. Increased patient complexity means there are more patients, for example with a higher BMI, who are less user-friendly, and there are more patients who are really comorbid and need a quick operation. The conflicting dichotomy of efficiency in the name of service provision and taking time for the sake of training is recognised by many. Lots of managers care more about long wait lists than about training and education, and they can put pressure on surgeons as a result of this. And more recently, the COVID pandemic has had a negative impact on the logbooks of trainees around the world. All these factors lead to what Sedati et al. Term education in the shadow of treatment. And that phrase, I think, summarises the state of surgical education in many operating theatres around the world. It's there, and it happens, but it's not a priority. But it is important that we address this issue of service provision being placed above education, because, as John Lunn puts it, if there's no training today, there'll be no surgeons tomorrow. Given the numerous non-modifiable impediments, it's important to focus on modifiable aspects, i.e. quality rather than quantity of training opportunities. As a profession, we need to move away from the apprenticeship model of learning towards guided discovery, and I believe this is happening to a certain extent already. The idea of 10,000 hours of practice to become an expert was popularised by Malcolm Gladwell's book Outliers. But what's required to become a good surgeon in today's climate is not just practice, 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 but deliberate, perfect practice. That's the difference between me being shown a couple of open inguinal hernias and then, once I've got the gist of things, being left to my own devices to muddle through, and after dozens and dozens of hernias getting reasonably good at them, compared to being shown a couple of open inguinal hernias with very specific explanations about the anatomy, technique, steps, pitfalls, and then being watched closely with errors being corrected in real time, so that with every hernia I do, I make a significant step towards the expert level. We simply don't have time for the discovery model of learning, and the inevitable mistakes that go with it are not acceptable to our patients nor ourselves. We have to move toward guided discovery learning and deliberate, ideally perfect practice. So how do we achieve this? Well, the good news is, I think that surgical trainees are very similar to border collie puppies. They are the perfect students. They want to work, they want to learn, and they want to please. So when you teach a border collie a new trick, you have to have a goal, and you have to communicate that goal to the dog. You also need to give them feedback so they know if they're doing it right. If you want to have an obedient dog, it's not enough just to take them to the beach and call his name and expect him to come back. You have to actively plan to train him good recall and start in an environment where he's going to succeed and reward him for coming back. My dog loves cheese especially. And then you build up the difficulty of the task until he'll come back to you when you call, even if he's chasing a rabbit. Now, the even better news is that surgical trainees speak the same language as you, and so that communication of goal setting and feedback is easier and probably doesn't require cheese. But just like a border collie, surgical trainees are not telepathic, so you do have to actively communicate. Within the literature, there's consensus that effective teaching in the operating theatre spans 3 phases: preoperative, intraoperative, and postoperative. A discussion preoperatively is vital for setting and agreeing goals and learning objectives. It helps direct the learning that's going to happen, and it reduces stress by creating a shared mental model. Intraoperative teaching improves performance and can reduce procedure time. I think the majority of the teaching that does occur happens during this phase. Post-operative feedback is essential for consolidating learning points and future improvements, but lots of studies show that these things happen infrequently at best. To be effective, training needs to be active and planned. Feedback needs to be routine, forthcoming, and constructive. So, how do we actually achieve this? Well, I'm not sure, but my suggestion is to use the Surgical Education Checklist. This is a tool that I developed with many lessons from the education literature in mind, and it's designed to piggyback onto established routines of briefing, timeout, sign-out, and debriefing. The conversations that the checklist prompts can be initiated by either party, the trainer or the trainee. The tool is pretty self-explanatory, so I'm not going to overly labour the point, but we'll just run through each section briefly. The briefing ideally happens before the start of the list. If both trainee and trainer attend the safety briefing, it can be done at the end of that. But if ward rounds or other commitments make that difficult to achieve, it can be done the day before, for example, and it doesn't have to be done face-to-face, it can be done over the phone. It provides an opportunity to check who'll be at the list, including junior members of the team or medical students, and what their level of experience is. Or if it's a trainee you work with a lot, it's an opportunity to remind yourself of relevant goals from recent feedback. It should be broadly decided who's going to do which steps of which cases. And it's also an opportunity to flag issues or commitments like, it's my daughter's birthday today, so I really need to get away on time. It's rare that a trainee will go from assisting with an operation to performing the whole operation skin to skin. We often break operations down into certain steps, and once easier steps are mastered, the more complex steps can be attempted. This is called part task training, and it's a useful tool in building up to performing more complex operations. Deciding which part of each operation would be appropriate for the trainee to do, if they are not capable of doing the whole operation, is good to do ahead of time. Setting goals helps direct the learning that happens intraoperatively, and it maximises potential learning opportunities. Discussing these aspects ahead of time creates a shared mental model between the trainee and the trainer, and it can reduce stress during the rest of the day because everyone knows what's going to happen. The next section is done before, during, and after each case, just like the safety checklist. Whilst scrubbing, or just before the start of the case, you can remind yourselves who's doing what, discuss any steps in more detail where relevant, and decide on the level of supervision that's appropriate, and any anticipated difficulties and what the rescue will be. As a trainer, for example, if you anticipate that Carlo's triangle dissection is going to be quite difficult, and you're going to have a low threshold for taking over in this lap Coley, verbalising this preoperatively helps reduce a feeling of failure for your trainee if and when this situation eventuates. Many surgeons are familiar with this framework around levels of supervision, which was originally proposed by Dr. Ruschenberger, who's a thoracic surgeon in the US. An important point to highlight is that the trainee doesn't have to be holding the knife for an operation to be a useful learning opportunity. Show and tell can be an incredibly valuable learning opportunity if utilised well. It's good to think about what stage of supervision is appropriate for a particular trainee, for a particular operation, and for that particular patient. Where one trainee may just need dumb help for a straightforward lap Coley, they may still need smart help for a difficult one. During the operation, remember what the agreed goals are. Give specific feedback along the lines of keep doing that, stop doing that, try doing this instead. If the trainee is struggling, as long as it's safe to do so, try to pause and question rather than taking over. For example, saying, looks like you're struggling with that dissection. What could you do differently to optimise your view? A safe struggle within the zone of proximal development is where most learning takes place. The notion of the zone of proximal development was first described by Vygotsky in the 60s, and it remains an important concept in the acquisition of practical skills, such as surgery, whereby the learner progresses their skill level in the presence of a more experienced trainer who can provide feedback. This is sometimes referred to as the growth zone as opposed to the comfort zone, which is what they can do independently, or the panic zone, which is beyond their capabilities. Helping your trainee maximise the time spent in this zone will help their learning. If they just do things that are easy for them and the operation gets taken off them when they start to struggle, they lose an opportunity to learn. Equally, if they're pushed to do something beyond their capability, it will have negative implications, potentially for the patient, but also for their confidence in learning. It's also important to be mindful of the verbal interactions occurring during an operation. Roberts et al. Did a study looking at verbal teaching interactions in the operating room and identified 4 main types that occurred. Instrumental interactions were intended solely to move the operation forward. Pure teaching interactions served to educate the trainee, shape judgment, or enhance performance. Instrumental and teaching interactions were directive but also contained teaching, and banter was discussion that was unrelated to the operation. Clearly, the sweet spot is around maximising discussion and interactions that are educational and also serve to advance the operation. At the end of each case, ask, how did that go? Did we achieve the goals? Why and why not? Because of X, Y, and Z. Feedback's an interesting thing. It's universally acknowledged that feedback is essential for improvement and progression of skills, but much of the literature demonstrates it happens infrequently. There are several papers that show that trainers think they give more feedback than trainees think they receive, and this is called feedback disconnect. If a trainee is given feedback when their cognitive bandwidth is maxed out with the task they're performing, they may not remember or recognise the feedback. It needs to be delivered and or reiterated later when they are more able to remember and consolidate. It can also be helpful to label feedback as such, and ideally should happen as a feedback conversation that both parties are actively engaged in, rather than feedback being delivered to a trainee in a one-way conversation. So that's your pre-op, intra-op and post-op education checklist. And if you're just doing an acute case and not an elective list, then that's all you need to do. But if you are doing an elective list, at the end of the day, it's really good to get together and have a debrief. Catch up with your trainee and ask them what they want feedback on. Review what went well and what didn't go well during the day, and ensure that feedback is specific and use it to develop goals and learning points for improvement. Education in the operating theatre is complicated, and it's often not prioritised. We've discussed that we need to move towards guided discovery with deliberate, perfect practice, and we need to establish goals pre-operatively. We need to maximise the time a trainee spends in their zone of proximal development by thinking more actively about what stage of supervision is appropriate, the type of interactions and discussions we're having during the case, and we need to give feedback. Using the surgical education checklist may help achieve these goals. But I just want to highlight a couple of things. This checklist does not tell you how to teach surgery. It's prompting and encouraging education-focused discussions throughout the day. Nor is the point of it to say, let your trainee operate more. It's about saying, put your cards on the table. Let your trainee know what you're thinking and what your plan is. It's also about empowering the trainee to bring up some of these things, to give them an opportunity to say, I haven't worked with you much, but I've been doing these skin to skin with the other bosses, so I wonder if I could do this case. It's so the trainee has an opportunity to say, I feel like I always struggle with this step. What do you think I could do differently? It's about normalising routine, constructive feedback to get away from the age-old adage of no news is good news, and if someone wants to give you feedback, you've probably messed up. Thanks for listening to my video, and my final question to you is, will you use the surgical education checklist? I hope so, and I'd love to hear about your experience.